Good morning and welcome to CLYM116 Investor Event focused on CLYM116 and the IgAN opportunity. At this time, all participants are in a listen-only mode. A question-and-answer session will follow with prepared remarks. Please note this call is being recorded. I would now like to turn the conference over to Dr. Carlo Tanzi of Investor Relations. Please go ahead.
Thank you and good morning. Prior to today's webcast, the company posted a presentation to its website, which may be found under the Investors and News section. Please note that various remarks that may be made during today's presentation about future expectations, plans, and prospects for CLYM116 constitute forward-looking statements, including statements about the timing of future data readouts from our ongoing and planned clinical trials, our clinical development plans for CLYM116, our expectations for the commercial opportunity for IgA nephropathy, our cash runway, and other statements which are not historical facts. Actual results may differ materially from those contained in these forward-looking statements as a result of various important factors, including those discussed in the Risk Factors section of our recent quarterly report on Form 10-Q, which is on file with the SEC. In addition, any forward-looking statements made on today's call represent CLYM116's views as of today only and should not be relied upon as representing its views as of any subsequent date. While we may elect to update these statements at some point in the future, we specifically disclaim any obligation to do so unless required by law. Any forward-looking statements should not be relied upon as representing CLYM116's estimates or views as of any date subsequent to today. Today, with prepared remarks, I'm joined by Dr. Aoife Brennan, CLYM116's President and CEO, and Dr. Edgar Charles, Chief Medical Officer. In addition, we are pleased to include Dr. Craig Gordon, a practicing nephrologist and professor at Tufts University School of Medicine. Following the presentation, we will open the call to a Q&A session, which will also include an additional member of the CLYM116 management team, Dr. Perrin Wilson, Chief Business Officer. And with that, I'll pass the call on to Aoife.
Good morning, everyone, and thank you for joining us today. I'm excited to welcome you to the first of several planned R&D Spotlight calls where we will share updates on our pipeline programs. On today's call, we are shining the spotlight on our newest candidate, CLYM116, discussing the opportunity in IgA nephropathy, sharing data from recently completed preclinical studies, and discussing next steps in development for this exciting program. At CLYM116, our strategy is focused and deliberate. We're developing differentiated monoclonal antibodies against validated B-cell targets with clear development paths in indications that offer meaningful therapeutic and commercial potential. We set a high bar for success, and we're making meaningful progress across our portfolio. Our approach is grounded in scientific rigor. We prioritize clinically validated targets, leverage the established monoclonal antibody modality, and focus on diseases with well-defined endpoints and established regulatory pathways. We move forward when we're confident we have an opportunity to make a real difference for patients with immune-mediated diseases. Our pipeline is anchored by budoprutug, a B-cell depleting CD19 monoclonal antibody that has potential in many B-cell mediated diseases and is being developed in both IV and subcutaneous formulations. The budoprutug team at CLYM116 has hit multiple milestones already this year, including dosing the first patients in the systemic lupus erythematosus and immune thrombocytopenia trials in the first half, and initiating the primary membranous nephropathy and subcutaneous trials earlier this month. All 4 trials are now actively enrolling, and we're looking forward to continuing to share progress and data with you in future communications as part of this Spotlight series. Today, we're turning the spotlight to our second program, CLYM116, which we expect will enter the clinic later this year, subject to regulatory clearance. This program is a strong strategic fit, complementary to our lead assets and aligned with our core focus. We in-licensed CLYM116 from mAbs in January of this year. It checked every box: a high unmet need indication, a large commercial opportunity, and early preclinical data that pointed to a potential best-in-class profile. We're co-developing the program with mAbs, who retain rights in Greater China, while we maintain rights and lead development and commercialization in the rest of the world. We plan to continue to partner with mAbs throughout development and leverage their operational footprint and capabilities to expedite progress. IgAN is an important cause of end-stage renal disease. There are over 170,000 patients with IgAN in the US alone, and that number has the potential to grow based on updated guidelines, which lowered the threshold for diagnostic kidney biopsy in patients with proteinuria, as you will hear about later from Dr. Gordon. IgAN is mostly diagnosed in asymptomatic patients, so a medicine that can address the root cause of the kidney damage, that has the potential to be safely taken over long periods of time with low patient burden and high compliance, has potential to be the cornerstone of future treatment. In addition to representing a large and growing commercial opportunity, IgAN has other features that are favorable from a drug development perspective, including an established regulatory pathway. Thanks to work done to demonstrate the relationship between proteinuria and long-term kidney outcome by others in the IgAN space, there is an established accelerated approval pathway based on reduction of proteinuria at 9 months. You'll hear more today about why we believe CLYM116 is a compelling opportunity in IgAN. Sweeper antibodies have been developed successfully targeting other soluble biological targets. As the only sweeper antibody targeting APRIL in development, we're excited to evaluate how CLYM116 can address some of the gaps in therapy that currently exist for patients. Earlier this year, when we announced the collaboration with mAbs, at the time we had an exciting molecule with a novel design and mechanism of action. Today, we will outline how those design features translate in vivo in a highly relevant animal model, the non-human primate. Given the competitive space, we wanted to put CLYM116 to the test with rigorous head-to-head studies versus sibeprenlimab. We're thrilled to share the preclinical results today that demonstrate that CLYM116 may offer meaningful advantages over first-gen approaches, including the potential for a differentiated profile with both longer PK and deeper and more durable IgA reductions, translating to the theoretical advantages of this new mechanism into in vivo differences in activity and kinetics. We're on track for phase 1 initiation in Q4 this year and expect to have initial data from the trial mid-year 26. Prior to jumping into the data, we're pleased to be joined by Dr. Gordon to provide some background context on IgA nephropathy based on his extensive clinical and research experience in renal medicine. Dr. Craig Gordon is a nephrologist and co-director of evidence review at KDIGO Clinical Practice Guidelines for the treatment of IgA nephropathy. Our discussion today is timely, coming on the heels of the recently published practice recommendations on which Dr. Gordon was an author. Over to you, Dr. Gordon.
Thank you so much. So IgA nephropathy is a common condition compared with all of the other glomerular disorders. Its incidence is at least 2.5 per 100,000 individuals, with higher incidences in Asian Pacific populations. The median age of diagnosis is 40 years of age, And data from the UK RADAR registry reveals the median kidney survival time is 11.4 years. So combined with the early age of diagnosis and this short survival time, IgA nephropathy is a major cause of kidney failure during a patient's lifetime. So can we do better than the time-honored ACE inhibitor and ARB therapy? With the answer being an emphatic yes. There's so many new treatments available, ranging from hemodynamic treatments listed here to immunosuppressive treatments listed in the second bullet. The question remains, though, which combinations will be used? Will we combine hemodynamic and immunosuppressive therapies? Very likely yes. What about multiple immunomodulating treatments? Again, likely yes. And then finally, for which patients, when in the disease course, and for how long? So here's the data from the UK RADAR registry. You can see in panel A that with adults represented in the pink line, on the x-axis is time from diagnosis to kidney failure or death, and on the y-axis is the probability. You can see here around the 11-year mark, 50% of people have progressed to kidney failure. And if we look out further at the 30-year mark, over 75% of people have progressed to kidney failure. So for those in panel G who are young of age at diagnosis and with rapid annual eGFR decline, the chances of experiencing kidney failure are nearly 100%. So here's a patient case that's a recent patient of mine that highlights the challenges. This 46-year-old male was referred for hematuria, proteinuria, decreased GFR, and importantly, no symptoms. His blood pressure was elevated, as you can see, and his urinalysis revealed both blood and protein. Urine protein to creatinine ratio was 2.9 grams, which is substantially higher than some of the values we'll be speaking about later in the talk. His eGFR was reduced from normal at 58 mLs per minute. I want to emphasize the disease progression in the form of decreased GFR that's occurred in the absence of symptoms. The patient underwent biopsy which revealed IgA nephropathy. And on the Oxford classification or MEST-C score, he scored an M1, E0, S1, T0, C0. And you can see what these terms represent in the subsequent line. He was initiated on an angiotensin receptor blocker, and then we held discussions with him regarding additional treatment options. So one of the tools we used to discuss his risk of progression was the International IgA Nephropathy Prediction Tool. This is something that very easily can be done using information obtained at the time of the biopsy, including the GFR and proteinuria, systolic and diastolic blood pressure, demographic features of the patients, their treatments, and the use of the MEST score. When we plugged this in for our patient, choosing a 5-year time horizon, he had a risk of 50% decline in GFR or progression to kidney failure of 47%. And this very high value informed many of our discussions about treatment. So let's turn to the pathogenesis of IgA nephropathy. And here we turn to the 4-hit model, where various antigens, infections, and other GI exposures in the Peyer's patches of the galt tissue of the terminal ileum, these antigens result in both T-cell independent and T-cell dependent conversion to IgA positive B cells and plasma cells under the stimulus of BAFF and APRIL. These IgA positive plasma cells release the Gd-IgA1 in hit 1. In hit 2, autoantibodies are directed against the Gd-IgA1, resulting in hit 3, the immune complex formation. And in hit 4, these immune complexes deposit in the kidney, resulting in inflammation and injury. So there's a number of treatments that are under development or already approved targeting this 4-hit model. You can see the hits represented with hit 1 on the bottom left, hit 2 in the upper left, and hits 3 and 4 to the right. Those represented in this slide in green are treatments that have been FDA approved, including renoprotective therapies up there in the upper right, and enteric-coated or time-release budesonide targeting hit 1 in the lower left. Older treatments that have not been FDA approved and likely won't be include treatments like systemic corticosteroids targeting the inflammation in HIT4. You can also see in blue a number of inhibitors of various components of the complement cascade represented in blue and blocking HIT4, as well as in the upper left some of the APRIL and BAFF inhibitors that likely impact HIT1 in the disease onset. I want to mention the important role of surrogate outcomes in IgA nephropathy. So the FDA recognized the need for surrogate outcomes in studies of IgA nephropathy due to it being a slowly progressive disease. As a result, the FDA has allowed accelerated approval recently of treatments based on the improvement in proteinuria, with full FDA approval requiring subsequent determination of whether there's an improvement in the slope of estimated GFR or kidney function. And this pathway has been true for time-release budesonide, sparsentan, iptacopan, and likely will be the pathway for all new agents studied in IgA. Finally, I want to emphasize that outcomes that are of scientific interest may include decreases in Gd-IgA1 and APRIL. So this brings us to a recent publication earlier this month of the KDIGO Clinical Practice Guidelines in IgA nephropathy. KDIGO is an international organization responsible for the development and publication of clinical practice guidelines in nephrology across a wide range of conditions. The IgA guidelines were published in early September, and I should disclose for the purposes of this talk that I was served on the evidence review team and was one of the authors of the publication. So KDIGO has statements regarding a number of areas related to IgA. I'm going to cover a few of them today, including those related to diagnosis in this slide. So importantly, IgA can only be diagnosed by kidney biopsy at this point. There's no validated biomarkers for its diagnosis. And importantly, to allow early diagnosis and early treatment of IgA, which is very different than what happened with my patient, a kidney biopsy should be considered in all adults with greater than 0.5 grams of proteinuria in whom IgA is a considered diagnosis. Shifting to treatment, how do we define those at risk of rapid progression? So those are really defined by proteinuria. So proteinuria greater than 0.5 grams in this first practice point here is someone in whom we should initiate or intensify treatment. Okay, so this is substantially lower than the level in the patient I presented earlier. When we talk about treatment goals, the goal here is to slow and reduce the risk of progressive loss of kidney function, with the idea being that during the patient's lifetime, they don't progress to kidney failure. At present, the only validated biomarker that we can use for clinical decision-making is the level of protein excretion in the urine, which should be reduced to a minimum of 0.5 grams per day or less, and ideally 0.3 grams per day or less. And important, although not underlined here, is that this likely will require multiple treatment strategies. So consequently, the treatment of IgA nephropathy in patients at risk of progressive loss of kidney function is to simultaneously reduce the immunoglobulin A containing immune complexes and their glomerular injury, and simultaneously manage the consequences of existing nephron loss. The second bullet point is that we should use treatments proven to reduce the galactose-deficient IgA1. Presented as an algorithm, you can see at the top individuals at risk of progressive kidney function loss, and to the right, we move to the generic treatments of nephron loss, including RAS inhibitor therapy, DIRAs, and SGLT2 inhibitors. On the left side are the IgA-specific drivers of nephron loss, separated into treatments that reduce the synthesis of pathogenic IgA and those that slow the IgA immune complex-mediated kidney injury. And you can see here, Nefecon, or the time-release budesonide, is listed as one that is thought to reduce the Gd-IgA1, whereas there's no data for this with systemic corticosteroids. Finally, the bottom of the slide highlights the importance of clinical trials. And I should emphasize that although the guidelines were published in September of 2025, the literature date cutoff for them was over a year ago, just due to the delays in publication and getting things to press. So some of the newer therapies that have been published or under FDA approval are not listed in this algorithm. I'm going to shift to discussing our current understanding of the BAFF and APRIL pathways that are an exciting new and novel pathway that's being targeted in IgA nephropathy. So APRIL is a molecule that stimulates plasma cell proliferation and antibody class switching, which themselves lead to the production of the galactose-deficient IgA1 or KDIGO1. So blockade of this through the use of APRIL blocking therapy very likely reduces Gd-IgA1 and all of the downstream hits from there. So BAFF and APRIL antagonists have been developed, and in this slide you can see BAFF, the molecule, is represented in blue and APRIL in green. And the BAFF and the APRIL interact with a bunch of receptors on B cells and later stage B cells and plasma cells, as you can see on the bottom. With BAFF interacting more with more immature B cells, and APRIL with more mature, later stage B cells and plasma cells, which are thought to be very important in the release of the Gd-IgA1 in IgA nephropathy. In the middle of this slide, you can see a number of agents under development that are both BAFF and APRIL inhibitors, and to the right, those that are APRIL inhibitors alone. I will emphasize that all of these and many other BAFF and APRIL inhibitors are under active investigation, ranging from phase 1 to phase 3 trials with exciting evidence expected. All of them are administered parenterally, generally subcutaneously, and usually with dosing frequency of every 2 to every 4 weeks. So in comparison of our current treatment armamentarium in 2025, I wanted to summarize some of what I've been speaking about. I've tried to use the same color coding from my earlier slide to represent things that were either under FDA approval, FDA investigation, or likely not going to be. So for instance, corticosteroids are in yellow because they're not going to be submitted to the FDA for approval. The items listed in green, the time-release budesonide and endothelin antagonists, have received full FDA approval based on the presentation of proteinuria and GFR data. And on the bottom, iptacopan is under accelerated approval as the UPCR or proteinuria data is available, but the GFR data not currently available. And finally, all of the BAFF and APRIL inhibitors we've been discussing we're awaiting the data both on proteinuria and GFR. I'd like to emphasize that the first 4 groups of medications are all generally orally administered, whereas all of the BAFF and APRIL inhibitors are parenteral. And then finally, when we look at efficacy data, we can see the proteinuria and GFR data for some of the earlier treatments, and those that are relatively new either have just proteinuria or treatment results and efficacy to be determined. Finally, when we look at safety, and safety is very important in this condition because it's very likely that the treatments we use will be long-term treatments targeting HIT1 as well as HIT4 in particular. And you can see here that there are safety concerns to be aware of for these various agents, including infections with systemic corticosteroids, steroid-like side effects with budesonide, so there is some absorption. There's the need for monitoring. You can see some of these items are starred, requiring REMS monitoring for some of the other treatments. And of course, this is to be determined for the BAFF and APRIL inhibitors. So to conclude, where are we going in the future? And I'm going to turn back to the KDIGO guidelines, which propose here in this box that we use combinations of medications targeting different points in the IgA pathways is likely going to be more effective. And also that maintenance immunological therapy, similar to what we do in other glomerular diseases, for instance, lupus nephritis, is likely to be required. And this is really because none of the drugs approved alone reduce the proteinuria or improve the GFR slope sufficiently to prevent dialysis in the lifetime of IgA nephropathy patients. So likely in the future, we're going to move to combinations of medications and needing data requiring combinations of those treatments, and likely an update to the IgA guidelines. So thank you, and I'll turn over to Dr. Charles next.
Thank you, Dr. Gordon, for your comprehensive overview of the pathogenesis and treatment of IgA nephropathy. As you highlighted, there have been tremendous advances in our understanding of IgAN over the past decade. And as a result, there have been recently approved treatments for IgAN, with several promising investigational therapies in late clinical development. Even with these advances, however, there remains a need for therapies that are yet more effective, safe and well tolerated, and offer less frequent, more convenient dosing for patients. Over the next several minutes, I'm going to describe why we at CLYM believe that CLYM116, our investigational anti-APRIL antibody, has the potential to be a best-in-class therapy for patients with IgAN. As Dr. Gordon described, APRIL, since it drives the generation of pathogenic Gd-IgA1, is critical for hit 1 in IgA nephropathy pathogenesis, as it sits on top of the pathogenic cascade. APRIL also contributes to hit 2 of the cascade, as it impacts the generation of autoantibodies, which react with Gd-IgA1 and form immune complexes that deposit in the glomeruli, causing kidney injury. Targeting APRIL offers the potential for a disease-modifying approach in IgAN. It acts early and through multiple steps of the IgAN cascade. The causal link between IgA production and specifically Gd-IgA1 production with IgAN pathogenesis, combined with the fact that these immunoglobulins can robustly be measured quantitatively, makes them informative dynamic biomarkers for early-stage clinical studies. We believe their use allows for rapid ascertainment of proof of concept in dose selection. Proteinuria reduction is a strong predictor of eGFR stabilization, which itself is a robust indicator of kidney function. Thus, longitudinal assessment of proteinuria in early clinical trials allows for predictions of efficacy in stage-gated decision. APRIL has been validated as a therapeutic target for IgAN in several early and late-stage clinical trials. Selective anti-APRIL monoclonal antibodies like sibeprenlimab, as well as dual inhibitors of APRIL and B-cell activating factor, or BAFF, such as atacicept, have shown significant reductions in proteinuria, as measured by the urine protein creatinine ratio, or UPCR. Comparing across different clinical trials, noting that caution should be exercised when comparing cross-trial data, reductions in UPCR with sibeprenlimab have been numerically better than what has been observed with atacicept. This suggests that BAFF inhibition does not provide an efficacy benefit beyond APRIL inhibition alone in IgAN. This is perhaps not surprising, as BAFF's role in IgAN is less well established than that of APRIL. Thus, an APRIL-only targeting approach appears to be a cleaner way to target IgAN. It avoids the potential immunosuppression associated with BAFF inhibition, and it does not appear to incur a trade-off in efficacy in the case of sibeprenlimab. As first-generation anti-APRIL agents, such as sibeprenlimab, have set the bar for the anti-APRIL class, next-generation anti-APRIL agents have the opportunity to deliver differentiated profiles based on improved efficacy and less frequent dosing with acceptable safety and tolerability. In the phase 2 study of sibeprenlimab in IgAN, dose-dependent effects on APRIL suppression, IgA suppression, and proteinuria were observed. Importantly, dose-dependent effects were also observed for the percentage of patients who went into complete proteinuric remission, which is defined as less than 0.3 grams per day of proteinuria, and which is a key therapeutic goal. However, only approximately 12% of patients who received 4 milligrams per kilogram every 4 weeks, which approximates the fixed dose regimen of 400 milligrams every 4 weeks that's been used in phase 3, reached complete proteinuric remission at month 12. Approximately 26% of patients who received 8 milligrams per kilogram, the dose that more completely abrogated APRIL, achieved complete proteinuric remission. Importantly, the safety profile was similar across the dose groups, even in the high-dose group that fully suppressed APRIL. These results suggest that deeper APRIL suppression may lead to more robust proteinuria reduction and higher proteinuria response rates. Next-generation anti-APRIL agents have the potential to provide deeper APRIL suppression and get more patients into proteinuric remission. And they also have the potential to provide more prolonged APRIL suppression while maintaining the favorable safety and tolerability profile of the first-generation anti-APRIL agents. Importantly, a minimally burdensome therapeutic profile is critical for patients with IgAN, as they will likely require lifelong treatment. Less frequent dosing and acceptable safety tolerability would be expected to result in durable treatment compliance and consistent long-term real-world efficacy. CLYM116 is a next-generation anti-APRIL monoclonal antibody that, to our knowledge, is the only anti-APRIL sweeper in development. To function as a sweeper, CLYM116 has been designed to facilitate its own recycling through high-affinity binding to the neonatal Fc receptor, or FcRn, as well as to eliminate APRIL through high-affinity pH-dependent APRIL binding. It has also been engineered to selectively target APRIL solely for neutralization and elimination. Validated Fc mutations have been introduced to diminish effector function with minimization of off-target immune activation. For these reasons, we believe that CLYM116's design offers the potential for best-in-class efficacy. We will be presenting in a few moments our data that supports this mechanism. Let's dive a little deeper into the CLYM116 sweeper MOA. CLYM116 can be likened to a targeted, iterative APRIL disposal mechanism. CLYM116 binds with high affinity to APRIL at neutral pH. Its binding affinity for APRIL dramatically declines as pH declines. Thus, CLYM116 is engineered to bind to circulating APRIL in extracellular space. Following endocytosis of the CLYM116 APRIL complex, the design of CLYM116 allows it to release APRIL in the acidic environment of the endosome, and APRIL is free to be subsequently degraded in the lysosome. Meanwhile, the design of CLYM116 allows it to bind to FcRn at the acidic pH within the endosome, and it is shuttled back to the cell surface, bringing it to participate in further rounds of APRIL degradation. This sweeper MOA has the potential to provide more profound and prolonged APRIL suppression following each dose, which in turn could result in clinical benefit. Our in vitro studies support the sweeper MOA and show how it is mechanistically differentiated from the first-generation APRIL inhibitors, ciproprinolol and zigakibart. Here, CLYM116 demonstrated binding to APRIL in a pH-dependent fashion in contrast to the other APRIL inhibitors. In all panels, concentration-dependent binding of anti-APRIL antibody to APRIL was shown. The curves with the solid symbols represent binding at pH 7.4, and the curves with the open symbols and lines in pink represent binding at pH 5.8. CLYM116, depicted on the left, shows high potency for APRIL binding at neutral pH. However, when the pH is lowered to 5.8, which mimics the acidity of the endosomal compartment, CLYM116 has markedly abrogated binding to APRIL. In contrast, neither ciproprinolol on the top right panel or zigakibart on the bottom right panel have meaningfully reduced potency for APRIL when pH is reduced to 5.8. Building upon this in vitro experiment, our in vivo experimental work provides additional evidence supporting the sweeper MOA. The next set of experiments were designed to test the activity of the sweeping mechanism. They interrogated whether CLYM116 more effectively eliminated APRIL and whether CLYM116 more efficiently recycled itself compared to first-generation anti-APRIL antibodies. In the study depicted on the left, anti-APRIL antibodies, either CLYM116 or ciproprinolol, were administered to mice. 36 hours later, the mice were injected with human APRIL, and concentrations of serum APRIL were subsequently measured longitudinally. As you can see from the green line, serum APRIL was maintained at low concentrations in the mice that had been administered CLYM116. In contrast, in the mice administered ciproprinolol, APRIL levels were initially reduced, but they increased by almost threefold by 6 hours. Thus, in this study, CLYM116 demonstrated more effective APRIL depletion and clearance compared to sibeprenlimab. This study was followed up by a study designed to assess the efficiency of recycling of CLYM116 following its binding to APRIL. In the study depicted on the right, mice with human FcRn were used, since human antibodies bind to mouse FcRn less efficiently. These mice were administered anti-APRIL antibodies, either CLYM116 or sibeprenlimab. 48 hours later, mice were injected with either human APRIL or buffered saline at the time point noted by the vertical dashed line. Serum concentrations of the anti-APRIL antibodies were measured over time. In mice that had received CLYM116, depicted in green, the exposure of CLYM116 continued to be maintained after the addition of human APRIL. CLYM116 concentrations were similar to those in the mice that had been injected with CLYM116 but did not receive APRIL, supporting the efficient recycling mechanism of CLYM116. Put another way, in the presence of APRIL, the PK profile of CLYM116 was similar to its PK profile in the absence of APRIL. The results are consistent with our in vitro data and suggest that CLYM116 is able to disassociate from APRIL effectively under low pH conditions, such as in late endosomes after internalization, leading to the effective recycling of CLYM116. In contrast, in the mice that had been injected with sibeprenlimab, depicted in gray, the exposure of sibeprenlimab decreased by over 90% after addition of APRIL, compared to the mice that had been injected with sibeprenlimab but not APRIL. Taken together, both of these studies provide experimental evidence for the CLYM116 sweeper mechanism, and they support the potential of CLYM116 to provide deeper and more durable degradation of APRIL. On the next slide, the in vivo PK and PD effects of CLYM116 were assessed in non-human primates. This pilot study in NHPs was ongoing when we in-licensed CLYM116 this past January. In this study, the PK and PD of either CLYM116 or sibeprenlimab, administered as single doses of 100 milligrams per kilogram, were studied in 2 animals per cohort. Data were censored for the 1 animal in each cohort that developed anti-drug antibodies, or ADA. Of note, ADAs often occur when NHPs are administered humanized antibodies, and the presence of ADAs in NHPs is not reliably predictive of human immunogenicity. CLYM116 demonstrated markedly prolonged exposure compared to sibeprenlimab in the evaluable animals. This was matched with deep and prolonged reduction of IgA. IgA suppression with CLYM116 reached 80%, and this level of suppression was maintained for over 168 days. In contrast, sibeprenlimab reduced IgA by only approximately 65%, and IgA began to rebound substantially after only 70 days. These data demonstrate the potential for CLYM116 to have a longer half-life with deeper, more durable IgA reductions compared to first-generation anti-APRIL agents. Although this was a small pilot study, it really excited us at CLYM, since it produced evidence of differentiation. We were eager to conduct additional research to demonstrate that these results could be replicated across studies and across different doses. We decided to build upon the pilot study with a larger head-to-head study of single matched doses of CLYM116 versus sibeprenlimab in NHPs with 4 to 6 animals per arm per dose. The objectives of the study were to confirm the bioavailability of subcutaneous CLYM116, as well as to assess tolerability, PK, and dose response, including assessment of biomarkers such as IgA, which itself is core to the pathology of IgAN. CLYM116 showed a favorable subcutaneous profile. The bioavailability was approximately 85%, which we were very pleased to see. Moreover, the prolonged exposure observed in the pilot study was confirmed. Importantly, there were no local tolerance issues or CLYM116-related safety findings, which was consistent with findings from our other NHP studies. The good bioavailability and prolonged exposure of subcutaneous CLYM116 observed here, coupled with the formulation's high concentration, low viscosity, and good thermal stability, support the potential for convenient at-home dosing. This study further showed that CLYM116 had dose-dependent prolonged exposure in NHPs. At both doses tested, 6 milligrams per kilogram and 30 milligrams per kilogram, CLYM116 demonstrated lower clearance and approximately a 2 to 3 longer half-life across doses compared to civiprinolone. At 6 milligrams per kilogram, CLYM116 had a half-life of 19.5 days compared to 7.5 days for civiprinolone. At 30 milligrams per kilogram, CLYM116 had a half-life of 24.2 days compared to 8.4 days for civiprinolone. The phenomenon of target-mediated drug disposition, or TMDD, has been observed with many monoclonal antibodies, including anti-APRILs. It occurs when a drug binds with high affinity to a target, and this interaction alters its pharmacokinetics. As you can see here, TMDD occurred at a similarly low plasma concentration for both CLYM116 and civiprinolone. It had minimal impact on CLYM116 clearance, and thus we believe it is unlikely to be clinically meaningful for CLYM116. We sought to compare the impact of CLYM116 and civiprinolone on IgA and NHPs, which, as I mentioned earlier, is core to the pathology of IgAN. After a single dose administered at 6 milligrams per kilogram subcutaneously, CLYM116 demonstrated over a 70% reduction in IgA, and a greater than 50% reduction in IgA was continued out through approximately 3 months. In contrast, a single matched 6 milligram per kilogram dose of civiprinolone achieved a maximal IgA reduction of only 50%. And by approximately 2 months, IgA levels had returned to over 75% of baseline. Taken together, these results indicate CLYM116 has the potential to result in deep, prolonged reduction in IgA at relevant clinical doses. Robust translational correlations from NHPs to healthy human volunteers to patients with IgAN suggest that CLYM116 has the potential for improved efficacy with less frequent dosing compared to first-generation anti-APRIL antibodies. Again, with the same caution regarding cross-trial comparisons, civiprinolone achieved a maximal 60 to 70% IgA reduction in NHPs, with doses of 2.5 to 10 milligrams per kilogram IV weekly for 4 weeks. Of note, this dosing schedule in NHPs was more intensive than the every 4-week administration that has been studied in phase 2 and phase 3. Povetacicept, a dual BAFF/APRIL inhibitor, achieved a maximal 50% IgA reduction in NHPs with single doses of 9 milligrams per kilogram IV. These IgA reductions in NHPs corresponded to approximately a 50% IgA reduction in healthy volunteers. They also corresponded to a 50 to 60% IgA reduction and a 58 to 64% UPCR reduction in patients with IgAN in phase 2 clinical trials. In contrast, CLYM116 at a potentially clinically relevant single dose of 6 milligrams per kilogram sub-Q achieved over 70% maximal IgA reduction in NHPs, suggesting a prospect for improved IgA and UPCR reductions in patients with IgAN. These results support a differentiated profile for CLYM116 with potential to be a best-in-class anti-APRIL therapy. Based on the strength of the preclinical package, we're excited to move CLYM116 forward into the clinic. We intend to initiate a first-in-human study of CLYM116 by year's end, subject to regulatory clearance. This study is intended to assess sequentially ascending doses of CLYM116 versus placebo in healthy volunteers, and it is expected to be a randomized, double-blind, and placebo-controlled study in order to robustly ascertain safety, tolerability, and PD effects. The planned primary objective is to assess safety and tolerability. Planned secondary objectives include PK and PD responses, such as APRIL reduction, IgA reduction, and impacts on IgM and IgG. Importantly, given the demonstrated translatability from healthy volunteers to IgAN patients observed in prior anti-APRIL studies, we expect this study to provide PK and PD data to guide dosing frequency, and a comprehensive study of efficacy and safety in patients with IgAN. We plan to share more details about the study design following study initiation. Our strategy for CLYM116 is a clinical development program geared for rapid progression and minimal white space between trial phases. Initial data from our phase 1 trial is expected mid-year 2026. Our decision to proceed into patients with IgA nephropathy will be based upon the depth and duration of APRIL suppression, as well as IgA suppression, in addition to safety and tolerability. These data are expected to inform dosing regimen, dosing frequency, predicted efficacy, and predicted safety and tolerability in patients with IgAN. Internal and validated external biomarker data provide opportunities for development program efficiencies. These data sets include first, PD clinical efficacy correlations between APRIL suppression, IgA suppression, and UPCR reduction, and linked to EGFR stabilization. And second, the observed safety tolerability profile of anti-APRIL monoclonal antibodies. Moreover, we expect that parallel execution of early-stage studies of CLYM116 by Mavericks in China will provide a complementary, independent data set that will allow fulsome stage gate decisioning. Finally, the established regulatory precedent for approval in IgA nephropathy provides a path for the clinical development steps required to support an application for marketing authorization. We are extremely excited about the results we have shared with you today. In preclinical studies, CLYM116 has demonstrated clear improvements in pharmacokinetic and pharmacodynamic measures, namely a longer half-life and deeper and more durable IgA reductions as compared to sibeprenlimab, suggesting the potential for a differentiated efficacy profile with less frequent dosing. We intend to leverage all of the above to help accelerate the development of CLYM116 and work to bring this potentially best-in-class therapy to patients. Thank you for your attention. Aoife, I'll hand it back over to you for a summary and close.
Thank you, Dr. Gordon, and thank you, Edgar, for the excellent overview of the CLYM116 program. As you've heard today, we believe CLYM116 has the potential to be a best-in-class anti-APRIL antibody. As you heard from Dr. Gordon, APRIL is an important target in IgA nephropathy and has been shown to address the underlying pathology driving the disease. The non-human primate data we presented demonstrate that CLYM116 has both longer half-life and deeper and more durable IgA reductions compared to first-generation APRIL monoclonal antibodies. Based on these data, we believe that CLYM116 has tremendous potential to be a leading therapy in the large and growing IgA nephropathy market. There's an established regulatory path and multiple biomarkers that can be measured early in development to support dose selection and rapid progression. We're moving carefully but quickly, with the clinical trial expected to start later this year and initial data expected mid-year 26. We're excited about the potential of this program to make a meaningful difference for patients with IgA nephropathy. Thank you again for joining us today. We will now open the webcast for Q&A.
Thank you. To ask a question, please press star 11 on your telephone and wait for your name to be announced. And to withdraw your question, please press star 11 again. And our first question comes from Colleen Kusy with Baird. Your line is open.
Hi, good morning. Thanks for all the information and thanks for taking our questions. Maybe the first one for Dr. Gordon, just with the current state of IgA nephropathy today, what rate of patients with suspected IgAN are getting kidney biopsies today? Just wondering if there's room for growth on the diagnosis side, and then just curious on your view on the therapeutic landscape and which of these endpoints you think will be most informative for your future treatment decisions.
Yeah, great question, and thank you for that. The first one about the biopsy is something I believe very strongly in, which is that as a specialty, we have to substantially increase the number of biopsies done. I think there's a number of years of sort of diagnostic nihilism about these types of things, which has led to people just assuming people had IgA but not proving it. The KDIGO guidelines, and I think a lot of other inputs into the system are pushing nephrologists more and more to perform biopsies at lower levels of proteinuria. So I think we're going to see, and we're already seeing, to be honest, quite substantial increase in the number of biopsies. If I talk to my pathologist at my local institution, she's seeing probably a 20–30% increase already, partially driven by this. Regarding the second part of your question, I think our current situation, obviously there's a number of FDA approved or agents under accelerated approval. One of the challenges, and I think KDIGO helps with this, but we'll need a revision and an update to that, is to sort of tease apart the wheat from the chaff, I suppose, as far as who needs which treatment at which point in time and which combination of treatments. And I think if we imagine the future, it's going to be even more therapeutic options as things that are accelerated approval reach full approval. Very likely we'll see APRIL inhibitors coming down the pike, and I think there'll very much be a need for experts and the guidelines and others to guide us as to which combinations of medications to use.
Does that answer your question, Colleen?
That does. Thank you. And maybe if I can squeeze a couple in for the company, some really compelling data. The 2 to 3 times longer half-life. Just curious if you have any initial thoughts on dosing frequency you'd be targeting. And then if you could just provide a little bit more color on the ADAs that you saw in the non-human primate models and what your expectations are for your immunogenicity of 116 in humans.
Sure. Maybe I'll take the first part and then hand over to Edgar to tackle the ADA question. So I think first and foremost, Colleen, what's most important for us is that we achieve full APO suppression. We do believe that there's potential for additional activity here with this class. And I think that's, we want to make sure that we have absolutely maximized that component before we start talking about, dosing interval. Obviously, what we've seen today really leads us to believe that we can address both and we can really do something that's very meaningful for patients and that's very clearly differentiated from first-gen approaches. But I think until we get more experience with the biomarkers and with the PK in healthy volunteers, I think we'll kind of postpone providing guidance on what that dosing frequency and dosing interval is going to be. But that's going to come pretty quickly. As we shared today, we're going to have top-line data mid-year next year. So I think with human data, we'll be able to give much more precise answers to how that therapeutic kind of profile is going to play out. But I think we're going to wait until we have those data in hand before providing any guidance around injection interval, but obviously a really important component, but not quite as important as getting the optimal efficacy for these patients to make sure we can truly stabilize kidney function over a long period of time for patients who are diagnosed midlife. We want to make sure that we're really getting a good efficacy with this therapeutic class. So maybe I'll hand over to Edgar to address the second part of your question.
Sure. So we did observe ADAs in our NHP model, which isn't too surprising. I mean, we have a humanized antibody in the form of CLYM116, and that's not unexpectedly can produce ADAs in NHPs. And ADAs in NHPs is commonly observed when humanized monoclonals are administered. And it is, of course, we and others have noted, immunogenicity in NHPs is poorly predictive of immunogenicity in humans. So, of course, going forward, we're going to be closely looking at ADAs in our clinical trials, but we have low suspicion that we will be immunogenic in humans.
Super helpful. Thanks for taking our questions. I'll hop back in the queue.
Thanks, Colleen.
And the next question will come from Thomas Smith with Leerink Partners. Your line is open.
Hey, guys. Good morning. Thanks for putting this event together, and thanks so much for taking the questions. Maybe first one for Dr. Gordon. I was wondering if you could just elaborate a bit on how you expect to select between really the multitude of agents targeting APRIL and BAFF/APRIL, and specifically, what's the most important consideration for you across efficacy, safety, tolerability, and injection frequency?
Yeah, great. Thank you for the question. Obviously, we need information about the differentiation of these different treatments as that information scientifically comes out. I imagine what we're really looking for is, among these various agents is going to be the level of clinical efficacy as far as proteinuria and GFR. Is there any differentiation there? And somewhat related to that is impact on IgA and Gd-IgA1 levels. I think equally important, I think, is the safety side of things, because this is very likely going to be quite long-term therapies, possibly years, if not decades in length. So that question of safety, tolerability is going to be very important. And then finally, I think with all of these BAFF and APRIL agents being administered parenterally, the dosing frequency is going to be very important. So I think something that is dosed less frequently will be a potential big advantage in this area.
Got it. That makes sense. And then one for the CLYM team, if I could. Very interesting non-human primate data this morning. Could you maybe just clarify and comment on the 116 epitope binding site and how that compares to sibeprenlimab? Is it the same site or a different site? And any specific considerations you would call out there?
Yes. So I think very important considerations, Tom. It's a different site to Sibi, and we will be sharing additional non-clinical data later this year at a medical conference that I think will really help tease apart some of the nuances here around epitope binding site and how that may contribute to high molecular weight complex formation. It's important, but we're sharing top-line data today around kind of the PK/PD, but I think there are several layers underneath that as well that we'll share in due course. But to answer your question directly, different binding site to Sibi.
Understood. That's helpful. And just a last question, if I could, for the company, and maybe Dr. Gordon would want to comment here as well. But just given the number of agents that are coming that are likely to seek accelerated approval here over the next couple of years in IgAN, can you just talk about some of the clinical plans with respect to trial enrollment and how you're planning to achieve efficient enrollment in a world with multiple approved advanced therapies? Thanks so much.
Yeah, I think that's probably, I'll get Edgar to answer that question, Tom, for you, if that's okay, because it's something obviously we've put a lot of thought into here as a company. So Edgar, do you want to talk through that?
Sure. So, IgAN is a highly prevalent condition, and it's currently undertreated, underdiagnosed, and undertreated. So we think that there are fairly many patients who could stand improved treatments and could be well served by going into clinical trials as recommended by the KDIGO guidelines. So we're going to be looking at how we perform in our clinical trials against standard of care, on top of standard of care and nephron-sparing regimens, as that type of regimen has been recommended in the KDIGO guidelines. When we go into clinical trials, we will be having a inclusion-exclusion criteria that are reflective of those who carry the disease, and of course, we'll be conducting global clinical trials.
Yeah, and I would add on to that, Tom, just to call out a key advantage I think we have is our collaboration with MAbWorks. So as you guys are all aware, about 60% of patients in the prior late-phase studies were Asian because of the prevalence of this disease in Asian populations. We've executed a non-clinical program that supports IND both in China as well as globally. So we're kind of global from the outset in terms of thinking about how to develop this asset, which I think will be very advantageous when it comes time to open up enrollment in the patient population once we get through these two phase 1 studies in healthy volunteers, one in China, one outside of China. We really have a great data set that will allow us to move very quickly, not just in the US, but also in Asia and some of the regions of the world that have been the most important contributors to the late-phase development programs that have been executed to date. So I think that's something that we've absolutely been cognizant of from the outset.
Got it. That makes sense. Super helpful. Thank you guys so much for taking the questions.
And the next question will come from Julian Harrison with BTIG. Your line is open.
Hi, good morning. Thank you for hosting this and for taking my questions. I have a few, and I'll just ask them all at once. First, I'm wondering if you believe 116 is sufficiently out of the woods with regards to risk of target-mediated drug disposition. Is that something you could sufficiently rule out with the NHP data shared today, or does that maybe require additional confirmation in the clinic? Second, I'm wondering how wide the expected therapeutic window is of 116 in humans. I understand you plan to share more details in the not-so-distant future about your upcoming trial, but are you able to give us a sense now for the dosing range that you plan to initially study? And then, Dr. Gordon, I'm curious how you envision the typical treatment sequence in IgAN relative to endothelin receptor antagonists when APRIL inhibitors become commercially available. It looks like there are profound opportunities to combine both classes, but I'm curious about how you're thinking about which treatment class you would maybe start first on a typical basis. Thank you.
Great. Well, I'm going to hand to Edgar first because I think we can knock off your first two questions pretty quickly, and then I'll hand it over to Dr. Gordon.
Sure. So we're really pleased with what we saw in the NHP. So, as you know, TMDD has been observed with many monoclonal antibodies, including anti-APRIL monoclonals. It occurred at similarly low concentrations for CLYM116 and CLYM116, approximately 5 micrograms per mil. And this is similar to what's been reported for JADE-001. Some differentiating factors for us seem to be that sibeprenlimab has a shorter half-life, above 5 micrograms per mil. JADE had a similar half-life and overall exposure to 116 above the TMDD threshold. And below the TMDD threshold, JADE-001 appeared to have a shorter half-life based on data from the 30 milligram dose. So we think we're differentiated from the other anti-APRILs. When we looked at our own data, TMDD had minimal impact on CLYM116 clearance, and we believe it's unlikely to be clinically meaningful for patients in the clinic. Pivoting to your therapeutic window question, our tox studies are complete, and we're really looking forward to going into the clinic at the end of the year. Anti-APRIL antibodies historically have shown a large therapeutic index. We have established safety and tolerability of the anti-APRIL class, and we certainly expect that to carry forward over in our compound. In CLYM116, certainly has shown good pharmacokinetics and PD effects in NHPs. We fully expect that to carry forward into healthy volunteers as well as patients with IgAN, and we expect to be able to dose at convenient doses and infrequent dosing intervals and achieve a very fulsome APRIL and IgA suppression.
Yeah, absolutely. And you asked a really key question, and I think the challenging thing in IgA is the heterogeneity of the patients. And people have said, if you've seen one IgA patient, you've seen one IgA patient. So our job in clinical practice is to determine how much of that proteinuria is from active disease and active inflammation versus prior damage. And that's going to inform our approach. So I think if we're seeing a lot of active inflammation, we might pick agents that target the inflammatory side of things, sort of the HIT 3 and 4. So this could be even systemic corticosteroids or complement inhibitors. When we're talking about the generic, hemodynamic effects, that's maybe something we're going to use in all patients, but for sure in those with less active disease, so mostly proteinuria without hematuria, and that's including the endothelin antagonists there. But I do think there's going to be a big role in this condition for lowering that HIT1, blocking APRIL, blocking the formation of the Gd-IgA1, and my suspicion is agents that target that part of the pathway are going to be really the strongest and most important part of our armamentarium.
Excellent. Very helpful all around. Thank you.
And the next question will come from Leland Gershell with Oppenheimer. Your line is now open.
Good morning. Thank you for holding this event and sharing the preclinical data. Couple questions. Just first, I want to ask, with respect to the upcoming phase 1 data, it looks like from the other agents in the IgA category, there's fairly good translation from preclinical to clinical in terms of IgA suppression. Want to ask, as we look forward to those data, are you expecting to see, 70% plus? Maybe if you could share just what you would like to see in terms of level of suppression and other efficacy metrics you're looking at as you look to take 116 into phase 2 and then a follow-up. Thanks.
Yeah, great question. So we're really excited to be moving into the clinic by the end of the year. And as you mentioned, we'll be looking at PK and PD biomarkers, which have good translatability into patients with IgAN. So we're certainly going to be looking at APRIL suppression. We're going to be looking at IgA suppression, which will give us a read-through to UPCR and eGFR stabilization in larger numbers of patients. So we certainly want to see a very competitive profile in terms of IgA suppression. We think that we have the ability to have full APRIL suppression over the course of the dosing interval, which will translate to result in very competitive IgA suppression. So we have that clearly in mind as a criterion for advancement.
Okay, thanks. And just wanted to ask, there's another candidate in development, for which one of the attributes is avoidance of immune complex formation. Just want to know if you could speak to the importance of this aspect in this setting, and what your thoughts are with respect to any interference that you may experience from the potential for immune complex formation with 116. Thank you.
Yeah, great question. So yes, others have reported high molecular weight complex formation and a reaction of the anti-APRILs with the trimeric APRIL, which can obviously bind to multiple antibodies and a daisy chaining-like effect of high molecular weight antibody complexes. We are not seeing evidence of significant HMW, and we're going to be presenting more data at a future medical conference this year to elaborate on this concept. But I think you can see from our PK and PD data and NHPs that we have a very competitive profile, and I think at the rate of TMDD that we're having at a very low level that's not affecting PK, we don't anticipate an HMW effect being important.
But we do have some
Thanks very much.
that we'll share later in the year that really puts a point on that. We just didn't include it in today's top line data presentation. So more to come, and watch this space for some of our in vitro work, just kind of really showing the importance of the epitope and how that impacts 116.
Great, thanks for the added info.
And the last question will come from Matthew Phipps with William Blair. Your line is open.
Good morning. Thank you for all the detail today and for Dr. Gordon's overview. I was wondering, you mentioned that MabWorks is doing a parallel execution here. I guess what data do you think will be available to help guide decisions kind of mid-next year after your own data? And then given this highly consistent data across these different programs from NHPs to healthy volunteers and IgAN patients, I guess, how much data do you need before really trying to step your foot on the pedal and accelerate into a registrational trial? Thank you.
Yeah, so great question. I think from a strategic perspective, what we've seen already, we believe is very compelling in terms of the historical data showing how the non-human primates translates to humans and then into patients with disease, as well as the data that we have and that we've highlighted today as part of our presentation. So we're moving, it's all gas, no brakes here from an investment perspective. We've initiated all of the studies that are going to be required to do clinical trials of longer duration. We're actively working with MabWorks to really design a very efficient late-phase development program. I do think it's going to be important to demonstrate proteinuria reduction in a cohort of patients with IgAN before enrolling, several hundred patients in a phase 3 blinded study. So at some point along the way, we're going to provide kind of those data as kind of an interim readout on the overall development plan. But you can expect that this is going to be very seamless with regard to stage of development, and it's going to be very seamless with regard to geography. And that's how we thought about this from the outset, really enabled with our collaboration that we've established with MabWorks that we're very excited about. So more to come as we get into next year and we start to generate data and have some of those regulatory engagements that are going to be really important to determine how quickly we can move here. But we're definitely moving with intention to develop this rapidly.
Now, I would like to turn the call back over to management for closing remarks.
Great. Well, thanks so much, everybody. Sorry we ran a little bit over time, but hopefully some great information, and we're certainly excited to keep everyone updated as we move forward to generate some human data and then subsequently data in patients. So thank you so much for your time and attention this morning. Thank you, operator.
Thank you. This concludes today's conference call. Thank you for participating, and you may now disconnect.